Introducing Dr. Ida Sim. Dr. Sim is a professor of medicine, UCSF, University of California, San Francisco, and computational precision health at UCSF, UC Berkeley. She also co-directs the UCSF, UC Berkeley Joint Program in Computational Precision Health. She obtained her bachelor's degree in biology, her MD and PhD in medical informatics from Stanford. A practicing primary care physician, Dr. Sim completed her internal medicine internship at residency at Mass General and a fellowship in general medicine at Palo Alto. I've had the pleasure of knowing and working somewhat with Ida for at least a decade, so it's a real pleasure to have you join us for this ethics discussion. I will turn it over to you and looking forward to your talk. Thank you.
Wonderful. Thank you. Thank you, everyone. I'm very excited to talk about this topic. I'll be framing some thought today on relational health AI and respect for persons, really from my point of view, from the trenches as an informatics researcher, also a health services and health policy researcher, and also as a primary care physician. So I'll be posing a lot of open questions. I'm really looking forward to the discussion. So does anybody remember November 30th, 2022, about 3 years ago, a little less than 3 years? This was the front page of the New York Times that day. It did not include something else that happened that day that was of great consequence. Does anybody remember what that was and want to say? Or I'm not looking at the chat, Camille or Brittany, but yeah, anybody remember what happened on that day? Well, GPT crashed into our world, right? With profound and interesting implications. Did not hit the front page, but I think looking back in time, that really is a momentous day. Not that that was a day that LLMs actually, were working, but because there was LLMs way before that. But this is when the public realized what LLMs can do. And it was a momentous time. So today, I'll introduce the notion of relational AI and how LLMs are a new third agent in healthcare, and share some reflections on the bioethical principle of respect for persons. These are some of my financial and other interests, none of which are relevant to the talk today. So before we start in on relational AI, let's first give a definition of AI itself. There are many, many definitions. This is the one that I use sort of operationally, that AI, it all boils down to this main idea that AI is when a machine can perform tasks or otherwise behave as if it were intelligent. It doesn't have to be intelligent, it just has to behave like we think intelligent beings behave. And this includes tasks like taking in data or input, processing that input in some way, or taking action in the real world. And I think it's helpful historically to think about three strands of AI. So back in the 70s, even before the 70s, when I was doing, med school in informatics at Stanford, AI was very much a symbolic AI. The Myson type of approach, rules-based artificial intelligence, it would be if-then rules, like if high wipe count and fever and consolidation on X-ray, then pneumonia. Okay, it was really that. And you could build chains of if-then rules to do reasoning. And of course, now we think, wow, like that isn't going to get you very far. But there was a sense of knowledge is power, and that if we could symbolically represent knowledge, that would get us to, this notion of AI that we've always wanted to get to. In the 80s, AI aimed to emulate the brain by building computer equivalent of a network of neurons. You're all familiar with this now. This is sort of the neural network approach. But for a time there was a real tug of war, right, between the sort of neural approach versus the symbolic approach as a way forward for AI. We're now seeing sort of neurosymbolic coming together, but there was quite a tug of war. But in the 2000s, I would say certainly the neural approach just blew the symbolic approach out of the water, right? Combination of powerful cloud computing, big data, really turbocharged this neuro AI into this modern era of what we might call machine learning. Okay, sorry, we need to advance here, right? So in the 1980s, neuro AI, 2000s, massive computing power, big data, Bringing in this sort of machine learning is sometimes we can conflate that in the public mind. Machine learning and AI, those are not the same thing. Machine learning is one way for a machine to behave intelligently, just one way. So what is machine learning? Because it's only one way for a machine to behave intelligently, machine learning, or ML, really is a subfield of AI. And here's a definition of ML actually from Health and Human Services in their trustworthy AI playbook from 2021. So this is before ChatGPT. The definition is a subfield of AI that gives computers the ability to learn without explicitly being programmed, includes probabilistic methods, and can support predictive analytics. Okay, so that's machine learning, which is a subfield of AI. There are many, many other fields of AI. Okay, much like statistics, actually, because in fact, ML is ML if you're in the computer science community. If you're from the statistics community, the same methods, same approaches, you might call it computational statistics, statistical computing. Basically, these approaches they're mathematical in nature. Okay, this is what we think of as sort of mathematical AI. And in medicine, ML has been used primarily for predictive analytics, using huge amounts of data. The big data is often EHR data, and deep learning methods and so forth to predict often a single outcome at a single point in time. So something like this patient has a 68% chance of requiring intensive care transfer within the next 24 hours, right? You've seen lots and lots of this, many, many years of many publications that focus on this kind of predictive analytics. And this is really the discourse around trustworthy AI in general. These are, again, the principles from the Trustworthy AI playbook from 2021 from Health and Human Services. You see them across, around this circle. I'm sure everyone's just very familiar with them. These are general principles, but I find often when we are talking about them and thinking about implementing them, that we narrow our frame to really trustworthy ML and predictive analytics, right? Because that's what we generally see in medicine and have been for a long time. And as I say, machine learning, if you're from the statistics community, it's really computational statistics. So again, if you think about mathematical AI, you could call this slide HSS principles of trustworthy machine learning and predictive analytics, or HSS principles of trustworthy statistics, and actually the same principles will apply. Right, the same principles of prediction, bias, fairness, if you're using logistic regression, any other kind of statistics, they really do apply. These are mathematical, AI in that sense. So you might ask, why am I belaboring this point? Because up until 2022, right, AI for medicine was mathematical. And the way we thought about ethics and trustworthiness was how it applies to mathematical algorithms. And then, of course, the socio-technical systems that are around how those algorithms are delivered. But, fundamentally, I think we sort of, go into the trustworthy ML and predictive analytics frame of mind, which was fine for that day. I mean, that was really what was going on. But of course, in 2022, LLMs like ChatGPT burst onto the scene, and computers for the first time could talk to us. Computers can relate to us as I am relating to you right now in natural language, in a wholly new type of AI. And Chris Castle and I wrote a paper in the New England Journal in 2024. We called this relational AI to really highlight the human relational aspects, and really distinguish it, this type of AI from, what I'm now calling mathematical AI. So what is relational AI? AI that communicates with humans through the medium of natural language, could be English, could be Chinese, French, with attendant emotional and psychosocial impacts and consequences. So it is fundamentally different from mathematical AI, like predictive analytics of the days of yore, of the old days. Now, you've probably all heard of Marshall McLuhan's "The Medium is the Message." I went down some rabbit holes and found that he actually used the term first in 1957, but wrote about it in 1964 in this paper. The medium is the message. So as LLMs relate to us through the medium of natural language, LLMs themselves are a medium, right? Just like TV is a medium. The medium conveys a message in and of itself. And as Marshall McLuhan puts it, the message of any medium and technology is the change of scale or pace or pattern that it introduces into human affairs. So let's ask ourselves for relational AI in healthcare, what change of scale or pace or pattern do LLMs introduce into the human affairs of medicine, what Chris and I call the emotional and psychosocial impacts and consequences. But as we say, that's not all. LLMs are also a type of cultural and social technology. It's expounded in this science article. The authors here, I'm sure you're familiar with. They've been thinking very deeply in this field. Certainly not my field. I'm just summarizing what I'm reading from them in their other writings and other authors. Cultural technologies, digital tools and systems that codify, summarize, and organize large amounts of individual knowledge, values, preferences, and actions, some would call culture in some sense, in a way that transmits that culture on a large scale and shape that culture in our daily lives. And examples they gave were the advent of print, language itself, and searching the internet. Those are cultural technologies. Social technologies, technological and other systems that allow humans to take advantage of information from other humans that have accumulated all that information so that new kinds of operations could be carried out at scale. And so that last phrase is very interesting. So as examples there, they give markets and the way that we enable economies at a scale that is possible because markets are a social technology, and bureaucracies, of course, allow us to do new kinds of operations. The upshot of this particular article was a call for LLMs to be seen not as the way that maybe Sam Altman and others might put it, as autonomous agents that may or may not become artificially general intelligent, AGI. Let's think about AI as autonomous agents, but more as cultural and social technologies that we as humans use and develop, and should be developed and managed in terms of their consequences for human culture, not in and of themselves, but in terms of their consequences for human culture. And I would add in the healthcare space, thinking about relational AI in addition, that we should be thinking about LLMs and develop and manage them also for the emotional and psychosocial impacts and consequences on healthcare, human affairs, healthcare relationships. So now traditionally, when we talk about human relationships in medicine, we tend to focus on the doctor-patient relationship. Yes, and it's so much more than that. Some of you may know Hugo Campos. He's a very prominent e-patient leader. Hugo and I were talking about these issues last year, and he told me that he was really worried about LLMs. He was really worried for doctors, because doctors will have a lot more to lose than patients, he said. And I said, well, why is that? And he goes, well, it's going to change your role. It's going to take away more and more of your autonomy as a physician. And it was very interesting. So we had more discussions, and we ended up writing this paper where we posit generative AI as a third agent in the clinic room or in the bedside, interposing itself between the doctor and the patient. And how does that change the way we think about some of these issues? So as I said, traditionally, there was only the doctor-patient relationship, which nowadays really we need to broaden out to the whole care team. So when I say clinician, it's shorthand for all my colleagues, nurses, physical therapists, pharmacists would really do practice as a team these days. And you know, being a patient is also a team activity. It's your caregivers, your mom, your grandma, your child. And this relationship between clinicians and patients, they're mediated by factors I'm sure people on this call have thought a lot about transparency, right? And trust, about information and power asymmetries, And of course, communication barriers, not limited to just language, but health literacy and so forth. And as we introduce LLMs as a cultural and social technology into this, clearly they're introducing new technical factors like LLM accuracy and fairness, patient health and technical literacy. There's actually technical literacy on the part of physicians as well. But in preparing this talk, I was actually thinking that LLMs being relational, the factors that affect patients and clinicians actually affect the other arrows here too. So this figure is already wrong. The arrow between clinician LLMs and LLM and patients also must, of course, involve transparency. Definitely includes trust and trustworthiness. It's a long conversation there. Information and power asymmetry. Doctors do tend to actually defer to a computer called automation bias. Because the LM is so confident, just psychologically, we just go, oh, okay, right? So there's a information asymmetry certainly for patients and the knowledge. Same thing with specialty expertise. We'll talk about that in the next slide. And then communication barriers. Obviously, the way that you prompt, the way that you talk to an LLM, you're going to get different things back. So this figure needs to be updated. Really think about the relationships among all these different agents. Today, LLMs are mostly functioning as a background, cultural and social technology, providing massive amounts of data, right, of info from other humans for us to act on. As I said, clinicians are using these tools like Open Evidence and ChatGPT. It is democratizing specialty expertise. I'm a primary care doc. It's easier for me to access that specialty knowledge. What does that mean for the culture and hierarchies in medicine? That's one thing to think about. It does actually change the culture, right? And then similarly, on the patient side, ChatGPT and other LLMs are democratizing medical knowledge far more than Dr. Google did in the pre-LLM days. Ran across an interesting article in JAMA that recounted a doc who thought that his patient was a healthcare professional because of the way she presented her history. And I've had this experience. Certainly, a patient comes in, they give me a linear history, and then they end with the pertinent positive, the negatives. I mean, they've been coached by ChatGPT. Hugo calls this patients relating them to themselves through ChatGPT to make sense of their own story. So that's sort of a self-relational thing. It's kind of interesting. But the other part is they're doing this to better advocate for themselves. When they come up with a story that doctors can hear, they're advocating for themselves in a different way. And, so how is that going to change when patients are coming in with this sort of prefabbed LLM coach history, right? Is that good for the doctor-patient relationship? I can certainly see it being good and maybe not good. ChatGPT and AI scribes, I have found, have been very impersonal in the way they summarize things. There's very little that's human or humanistic in medical LLM output. If a person comes in with sort of a clinical summary, what does that mean for that relationship? So in that sense, Hugo and I posited that LLMs are currently somewhat of an interrupter between the clinician-patient relationship. It can also be a facilitator, but we just need to think about what that means and what that looks like. What's coming, of course, is the trilateral agentic AI. LLMs are going to act fully as cultural, social, and relational AI. As that third agent, bilaterally with the clinical care staff and with patients or individuals who aren't even patients, as a matter of fact, right? And of course, there are direct participant in the relationship between the humans as well, right? Epic recently announced their AI agent Art and Emmy. Art helps clinicians draft responses to patient messages. I've been using it. We can talk about it in the Q&A. Emmy is designed to support patients between visits. That's a quote from Epic. And it'll draw on your EHR data to help you understand your test results. Emmy will also suggest next steps, answer open-ended questions, help patients stay on top of their healthcare, and help patients walk into the exam room with a clear picture. So again, it's mediating, helping, concierge, it's really being an agent. It's going to participate in the relationships of healthcare. So this future is both exciting and also troubling. LLMs will change the distribution of expertise, agency, and knowledge. And will I expect change the very nature of medicine as a humanistic profession? And so with that, I want to consider, or perhaps in some ways reconsider, the bioethical principles underlying clinical medicine. And I'm sure you're all familiar with the Belmont Report, its three main principles for the protection of human subjects for research, which is what it was geared towards. The three principles being beneficence, right? Maximizing benefits, minimizing harm, promoting well-being. Respect for persons in the research context, sort of more narrowly drawn to recognizing the autonomy of decision-making. So the agency to provide voluntarily informed consent is so central to the protection of human subjects. Privacy protection, protection of vulnerable persons like children and prisoners, and of course justice, selecting subjects fairly and that the risks and benefits are distributed equally among subjects in the research context, right? Now, these same principles are often applied to clinical medicine. Traditionally, physicians have been the one to hold the fiduciary responsibility for upholding these principles, the Hippocratic Oath and beneficence, respect for persons, and justice, to do so in the best interest of our patients. Just like the researcher is the fiduciary for human subjects, the physician has been the fiduciary for upholding these ethical principles for our patients. Well, note how paternalistic this all is, right? The doctor is the fiduciary, the patient is passive, they're subjected to clinical care or research of agency that's very narrowly drawn to informed consent. Of course, patients were never passive subjects of clinical care and will be even less so as they are empowered by LLMs. And as we've discussed, the role of clinicians is also changing. Right? In the clinic or the bedside, patients are not the only humans in the room. Right? Clinicians are people too. There's more than just the patient as a person. In this new trilateral world, clinicians also deserve the protections of respect for persons. And so this notion of respect for persons, I would argue, needs to be framed in beyond autonomy and privacy in the research context to recognize sort of the unconditional value of all persons involved in healthcare. Chris and I just sort of left that out as a statement in the article. Would love to discuss what this group might think that means. But for patients and for caregivers, how do we respect persons by attending to the humanistic impacts of AI for good or for ill? For clinicians, what does it even mean to respect their personhood as a physician, as a clinician, sorry. As Hugo points out, doctors do have a lot to lose around professional autonomy. I've actually been wondering when I'm going to get replaced by an avatar. They have 20 years of my practice patterns in the EHR, and now they have audio recordings because I use an AI scribe. So it already knows how I talk to my patients. So when am I going to get replaced? And will I have rights over my name, image, and likeness, just like college athletes do? In fact, there is a bill coming through the California Senate, SB 683. It's passed the House. It's going on to the California Senate to allow individuals to get a temporary restraining order to remove unauthorized digital replicas. I think we're going to start seeing this. What does it mean to respect me as a person when there are, these other agents that behave intelligently out in the world? And finally, anticipating the consequences of large language models as a cultural technology, how does respect for persons need to expand to respect for culture as the expression of respect sort of for collective persons, for persons, together, and how we have our shared thoughts, our shared actions, our shared values? How to respect collective persons, and is that a right way to frame it? So I really look forward to everyone's thoughts on these. These are ruminations that I've had that I think are worthy of discussion. So in summary, LLMs are fundamentally different, of course, from mathematical AI. They're relational, cultural, and social technology. They are becoming a third patient that's interposing itself, right, giving rise to this new sort of trilateral relationships. all humans in the room are deserving of respect for persons. And this notion of respect for persons, I think, would be helpful to expand that, to broaden that, to recognize the unconditional value of all persons involved in healthcare and to define what that might mean, to do so for us as humans singly, but also collectively in the culture of medicine and what that impact might be. So I'm going to end with the last paragraph from the article that Chris Castle and I wrote. So we are at a threshold moment. This was in 2024, but we're still at that threshold moment for shaping the nature of medical care in the near and distant future. The most crucial choices confronting the medical community are not technical, but ethical. The paramount fiduciary responsibility is to all humans and to the persistence of medicine as a moral and human profession. So thank you, and I am looking forward to a discussion.
Thank you so much, Dr. Sim. That was excellent. Really, really thinking through how does the healthcare system identify as an individual, like thinking carefully about all the stakeholders or actors that are in this environment, and both for healthcare and for health research. I see, Stephen, you have a question, so go ahead and come online.
Hi there. Thank you so much for that really great talk. I really appreciate it. I also really appreciated the bringing in the social technology piece. I loved that article by them. I have a question about the whole relational technology framing, though. How relevant is it? And this is like not me asking a gotcha. This is open and actual question. How relevant do you think it is to that framing that there is not actually any relationship happening on the LLM side, right? It's not understanding, there's no communication in the Gricean sense. It's somebody talking to a spell checker. They might think there's relation. They're bringing a lot. They're projecting a lot onto that interaction. But from the LLM side, there's none, right? There's not any. And the whole artifice is designed to create that illusion in the mind of the person, which I think raises some respect for persons questions right there. But so how, I don't know, how relevant do you think that is to the framing? And then where does the actual agent in that case is whatever health system implemented that LLM and chose to inject it in the interaction. So how does that kind of interact?
Yeah. I don't think it's, as I say, AI is machines acting as if they were intelligent. And in this sense, AI agents acting as if they are relational. They don't need to be relational. They don't only need to appear to be relational. When humans can fall in love with an LLM, right? Or it can be misled into paranoia and schizophrenia. Like, they're very, very powerful technologies. I know there's some talk even of respect for the rights of LLMs. I mean, that's going way too far, right? So like, yeah, it's wild. No, I don't think that's really germane what the LLMs, the fact that they are, stochastic parrots. I don't think that is, I don't worry about the LLMs and their rights. As their impact on humans, I think we take it for what it is, which is extremely, extremely concerning. And I also fully agree with you that these are not autonomous agents doing their own thing. These are instruments that are used by humans and institutions. These are socio-technical systems that our healthcare system is using to help us do what the health system wants. It's not the AI doing it. It's us and our humans and our, so it is a socio-technical system. But the implications and the effects of those socio-technical systems, given that these are LLMs and have a relational component to them, I think is something that's different from just saying that it's a social technology or a cultural technology. I think it being a relational, very personal technology that interacts with us the way we interact with each other. I think there's something really powerful and kind of amazing and scary about it. That's kind of where I'm coming from.
Thanks.
Other questions? Brad. Mute.
Yes, mute. I think this kind of brings up the age-old question of what do we want out of artificial intelligence, which is, do you want something that reasons and interacts like a human would, or do you want something that is capable of doing things that perhaps humans might not be capable of doing? And if that's the case, does that mean that there might be different types of interactions or structural interactions that you might not get when you're thinking about the way humans interact? So I'm curious about whether you could comment on this.
Yeah, again, I think the overall impact should be thought of as, what is the combination of AI and humans, and who does what, and how sort of as I say, the expertise and the knowledge and the agency are distributed in a different way, right? So I really do think that in the future, it'll be AI and doctors working sort of together. It's a two-part complementary system that we should be thinking about. So I think that opens up a lot of questions as to what are we trying to do, and how do we use this AI tool to complement what the humans should do? And I think we haven't even defined what it is that we want humans to do that only humans should do. And that's really kind of where I start. And it's a thing that it's kind of weird to ask, right? What is so humanistic about medicine? What is it that we need to defend? Even if computers can do it, should we? And I don't know. I don't have the answer to that, right? And you've seen the articles about how AI is more empathetic. Well, at the end of the day, you've heard about, all of us doing our charts and our inboxes. We're not as empathetic. And so is that good? Is that good that machines are more empathetic than humans, at least in the responding to my chart context?
Or if you have the agent situation that you were alluding to, under what conditions can the human be overruled by the agent? Because the agent may be a specialist in an area that the human is not. And at which point are you robbing the human of their own agency at that point? And so it kind of becomes this question of not just the human computer interaction, but we're now talking about potential for teaming and situations in which you have hierarchies and orchestrations of interactions that we weren't really thinking about a couple years ago, right? Like I think it's become like a really interesting and challenging situation for a lot of medical centers to say, well, what happens if I have not just a co-pilot, but I have an orchestrator that is overruling what certain humans might say, what certain physicians might say, because they go, no, that doesn't seem to be right in this situation.
Yeah. I mean, maybe a facile way to say, well, at the end, who's legally liable? It's the human, right? So but that doesn't answer the questions that you're raising.
Yeah.
And we'll get to the next question, but I also want to say that this isn't just on the physician side, right? When a patient goes through ChatGPT, and there've been some stories of people who go to ChatGPT with a symptom, and ChatGPT kind of talks them in some sense, to a particular presentation, right, with an assumption of a potential diagnosis. And then the patient kind of gets, because there's this information and power asymmetry, the patient might say, well, I've talked to ChatGPT and I know I have cancer. And they will go into a doctor's visit thinking they have cancer, right? Or maybe they have shaped the story in such a way that the physician now is thinking, oh, that's cancer, because I'm taking cues from the patient, right? So now when the patient comes in, it's not just an unformed story that I'm interviewing the way that I normally do. The patient has already been interviewed by ChatGPT. They've already coming in with sort of a prefab story that's already been either clarified or maybe shaped or maybe morphed. Like, how do we even think about that? Right. So those are, I think, yeah, is there autonomy, but there's also assistance, there's also empowering, patients, as I say, that patients speaking a certain way, doctors listen to them more, right? We've known that for a long time in the patient advocacy community. So it's very, very interesting. I know there's another question.
But before we go to you, Moni, I'd like to ask Kate if she'd like to come online and ask her question that's in the chat. I would ask it for you, but I don't know what, maybe you would know this, Dr. Sim. Is Kate here? Yes, thank you, Kate. Can you ask your question and just turn off your mute?
Sure. I have a perspective. The patient really is looking from a consumer perspective of what is my diagnosis and treatment plan. And so, like you just said, they go back and forth just to even get the medical lingo. So they show up at the appointment and go, well, this is called, ICD-10, so-and-so and so-and-so. So what is your perspective on, how should patients inform themselves on how to approach this? Should they say to their doctor, well, I was talking to ChatGPT, who knows if that's right, but can we have a dialogue around, could my diagnosis be this? Could my diagnosis be that? I just don't even know the possibilities or options. And that's why I went to ChatGPT, because I don't want a certain diagnosis, but I just want us to explore all options. What are your thoughts on that?
I think that's absolutely, the right way to go, right? And it's not like ChatGPT is new for physicians. Back when Google search came, we had this notion of people Googling their disease and coming in, right? So it's and I'm a primary care doc. I'm completely open to, where are you coming from? What are you afraid of? What if what are your fears? Like that's part of what I do. Is that something that we allow physicians the time for and the support? Not necessarily, but I think ChatGPT is actually another level beyond sort of unidirectional searching of information that we get from Dr. Google, right? When they're actually talking to ChatGPT in ways that are much deeper than just pulling back factual information. But yeah, we're already there. And I think it's good. I think it's good for patients to know more and to be a partner with their physician, because that really is fundamentally what's going on, right? We're co-pilots with each other, and the real pilot actually is the patient, because they're the ones who are taking care of themselves day in and day out. It's not me. It's a primary care doc seeing them 20 minutes, 3 times a year, right? I'm not the pilot. I'm absolutely not the pilot. But ChatGPT being in there, I think does bear some deeper thinking about what that means.
Thank you. Moni.
Cheers. Thanks, Dr. Sim. I was still thinking about earlier the thoughts on how do we enforce and how do we operationalize the respect for all persons, and so it made me think, if you're just using an agent from the perspective of a software development exercise, you configure your agent so that it has certain behaviors, and you make sure that you give it specific instructions in order to be able to get all this amount of information that comes from the other ends. And so I was just curious, what were your thoughts on this operationalization? Like, I imagine this has to be a multi-step, but if you had some thoughts on how do we get to this operationalization, and how do we respect all the persons? Yeah, I know it's a huge one.
Yeah, so we Chris Castle and I did suggest one thing in our New England Journal paper. Right now, there's been a lot of focus on large language models and how they perform. Are they accurate? Do they hallucinate? All that kind of thing. And there have been thoughts about, proposals to have sort of validation centers, right? So that to me is sort of like factory testing. First of all, you take a LLM and you factory test it, right? But then you put it out in the wild. And once it gets out in the wild, it's a socio-technical system, and the impact is both the solution itself, the technical solution itself, and of course the way that it's implemented, right? And so now we need to evaluate and validate in the field, in the wild. Very, very challenging. It's a lot of work on, how to evaluate for drift and accuracy and all this sort of the technical evaluation. But the ethical evaluation is also really, really challenging. And how do we articulate principles like respect for persons, which I think is actually very, very challenging. And then what's the mechanism to implement that, as you say, right? So we were drawing this notion from the NTSB, right? The National Transportation and Safety Board. There's a plane crash, you come in, you figure out what happened, right? Well, we can't do that with LLMs. We really need to be proactive and not wait until there's an ethical disaster. So we need to have, we proposed this sort of, network of sort of ethical centers that would monitor and engage in a discussion around the principles and around how we implement them, how we monitor them, and be transparent about them. Pie in the sky, but we thought just sort of conceptually, that's something that we needed. It has to be done not by the people who produce the solutions themselves, right? Not OpenAI or Google or Microsoft, and probably not even the health systems themselves, because the institutions are party to the effect, right? It's a socio-technical system. So then it should be a neutral party that's evaluating, and obviously not going to happen probably, but conceptually, it is kind of what we were thinking about. I don't know if others have thoughts on how we might concretely, implement some of these ideas and what structures might be needed.
This is amazing. I mean, just the thoughts that you were sharing makes me think about the need for, you just kind of like, you have to make sure that there's explainability and transparency when you're generating the tools, and the AI has to provide clear rationale, and then thinking of how you mitigate bias as a component of this respecting all persons too, and acknowledging uncertainty. But beyond the components of what the decision support agent is doing, then of course you also have to consider that dimension of the patient, right? Like the patient's autonomy and empowering the patient with accurate information too. Yeah, no, thank you so much for starting that. It's a good seed to plant.
Jorge.
Yeah, thank you so much for the time. Thank you, Dr. Sim, for the talk. I just wondering, and this is a personal struggle for me as I think about sort of relations between AI and the patient and the clinician, and also just like larger questions around ethics. I wonder around how we balance. It seems like this tool addresses one piece of the puzzle of like larger patient health. We also know there are other factors, social factors, things outside the clinic that this might address. I wonder how we balance like the investment and focus on AI versus like other factors in the larger healthcare discussion. And I don't know, that I just open question. I struggle with this myself in terms of like the patients that I see on the day-to-day. So I wonder how you've like thought through that kind of question.
Wow, the misdirection of resources, huge question. I think for AI in particular, I run a graduate program, right, in AI and medicine, and just seeing where the research is occurring and who can fund it now, especially with the current federal funding landscape. Really, the money for research is coming from industry. Some very large companies with their billions and billions of dollars and their foundational models that are very, very hard for academics to even come close to, right? We struggle with getting, one or two H100s, and, the companies have massive, massive resources. I was a chief research informatics officer at UCSF for the last couple of years, and know that, it's hard. I mean, we are not going to be playing on the same level as industry. Industry is going to partner with, they need data, right? To do this, they need data. Who owns the data? It's the health systems, right? So health systems are another sort of a mega entity. So you've got the health systems with the data. You've got large, large companies with deep, deep pockets. They're the ones who are driving the research agenda. They're the ones who are directing the resources that are available. So I think that's a real challenge. I don't know how we get our voice there, either as frontline physicians and as patients. And then the broader question of where we're, putting our resources. Well, that's huge. I don't have an answer to that. I do worry that we are, just look at the billions and billions of dollars that have been put into digital health way before, the AI, right? The sensors and all that. Billions and billions of dollars in there, and it hasn't really done anything. Right? It hasn't really done anything for real patients. Yeah, it's a big problem.
I really liked your idea about the transportation oversight structure. And I started to think about, like, I think Stanford has a body that reviews proposals that involve AI so that they can provide some guidance. And I remember, like, this has to have been about a dozen years ago when we got RWJ funding to create the Connected and Open Research Ethics for Digital Health People. We knew that researchers wouldn't know who to go to ask the questions. And they knew that IRBs were not sufficiently trained to be able to answer questions or see things that could be downstream risks. That holds true today. And the analogy that we had when we created that network was Stack Overflow. Like, if you were writing code and you needed somebody to take a look at it, to tell you where the bug was or what you forgot to think through, we need that kind of networked community that has so many different kinds of people that can, an anthropologist will see something completely different than a legal scholar or a computer scientist. And it's building that infrastructure that's going to be so critical. One of my colleagues, who you all may know, Laurel Rick, she's a roboticist over at UC San Diego. And I asked her, like, what are the issues, like, when you think about building these AI models, what are we not looking at? She goes, it's no different than when you build a big building on your campus. You have to have the HVAC, the civil engineers, you have to have this body of people that come and take a look at what your plan is before you ever break ground. And that's just not happening right now. So how do we get into a position where we're on track for that kind of infrastructure? I mean, when I think about who are the stakeholders in this? What are funders' responsibilities in this place? What are institutional responsibilities? I mean, I'm on the health data site committee for our campus. I know what industry's asking for when they're pulling for patient data. I see that, but is that generally happening? So I don't know. I'm just curious about what you see as the capacity building requirements for us to get on track.
Yeah, I think the capacity, the human capacity and the institutional capacity is huge. I think when, the whole ChatGPT thing came out in November of 2022, I think many of us, I'm sure, thought about our institutions and are our institutions positioned to respond? And I would say no. I mean, we're siloed. We've never thought about, UCSF is a health campus. We don't even have anthropology. We don't have computer scientists. But is this an interdisciplinary thing? And how do we build that institutional capacity to think about our priorities and to set up governance structures? I think it's very challenging. It's going to be even more challenging when in the healthcare sector, there's tremendous amounts of burnout. Right? I mean, it's really hard being in healthcare right now. And this is a huge thing that we need to do, and it needs to be done with care. And it's unclear who's going to come up with the money or the bandwidth to do it. I'm curious, as the University of California, is there something we could do? Because we have all the specialists, what does it even look like? And it might be interesting, and there may be others, as you mentioned, the Stanford example, and I don't know enough of examples of other groups that have been doing these more, multidisciplinary, oversight or partnerships. Patients need to be involved in a far more than just a token way. I know there've been some thought about using LLMs as a large scale, again, a social technology where people can, talk to the LLM to say what they want from something like respect for persons at a very, very large scale, and have the LLM summarize what 10,000 people think. Maybe we canvass, all the researchers funded by NIH, like, what do you think respect for persons means? And then have it summarized. I don't know. We have to be thinking out of the box about how do we tap into, the broader conversation and not do what we've always done, which is convene, some people who represent large segments of society and then fund them. And, we have to be more nimble and yet do it well. I think it's really challenging.
Yeah,
I don't.
I love that. And I think about respect for persons. In practice, that's always been linked to informed consent. And when I think about informed consent, it's so broken because we rely on IRB templates. If you look at informed consent to receive healthcare, it's probably an 8-point font. It's done on a tablet now. You can't scratch out what you don't agree to. A lot of people don't agree to things that are on those consent documents for healthcare. So when I think about respect for persons, it has to go way beyond informed consent. And yet that's kind of the default. And so I think maybe we should, and if you've already written a paper on what that looks like, is that the New England Journal paper? Is that where you?
No, that just followed out that clinicians also deserve, acknowledgement as persons. And that when we talked about respect for persons, it's more than just patients as persons, but it's also clinicians as persons in this sort of, big machine that we're in. And then reading that article on cultural and social technologies, there are societal effects of LLMs, right? It's not just each individual, but because of the scale of LLMs, that's really shaping the culture itself as well. And if IRBs narrowly focus on harm to individual patients, there's harm to the society and harm to culture as well. And where does that sit? So we've been struggling with that actually within our IRB. The IRBs are not, constituted to address questions of harm to culture and society. Where does that sit? And let's just narrow it to healthcare, right? There are just so many issues that are out there that we don't have structures for, don't have a capacity for.
It really requires a paradigm shift.
Mm-hmm.
And if we continue to use existing norms that don't fit the new system models, it's and I really do think funders have a huge responsibility in this space to push on our existing structures to inform how things get informed. So it'll be, and I think Bridge to AI has tried to do that in some respects by bringing in really diverse teams to develop these data generation projects. I noticed, Brittany, you put our next discussion forum in the chat. So I do hope others will continue to join us. Joe, did you want to close with your question or comment?
No, but since you put me on the spot, I will.
Right.
No,
Well,
I agree with the last bunch of comments from you and Dr. Sim. It's really a weird system of propaganda towards altruism and precision medicine and AI. And we collect that data, but the other part of the system is health delivery, which is still based on money, based on politics, and based on majority culture. So you're collecting all of this wonderfully precise data with no way to deliver it.
Yeah, I fully agree with your comment in the chat, and also Stephen's comment about regulation. I think we're still somewhat in the old paradigm where when we think about risks, we're thinking about the risk of our data. I mean, data's commodity now, it's all over, right? And yes, our data does need to be protected, but data also has value to society. And if we're using just the privacy frame, I think that's not balancing the societal benefits of health data as a public good, right? That's a whole separate discussion there. But then, once we get into the delivery system, all sorts of other incentives that I think are overpowering the kinds of things we're talking about today, and the role of funders, the role of our institutions. It's challenging, but maybe we have more wisdom from Joe.
Well, yeah, I mean, Stephen put there, it's used against them right now, because I'm Mexican. Right now, all of that data is being used by ICE to go and round up a bunch of immigrants in Chicago, right? And so you don't have any control of the government. I mean, everything changed, right? And it's a shame to be right, but myself and all my native colleagues from Australia and New Zealand and Canada and the United States are like, this was going to happen. We knew this was going to happen. And of course it did. It's all this data is being used against the people that the United States doesn't like. And that's not what was promised. We were promised better healthcare, right? But again, to that same point is these smaller populations, whether they're Amish or Ashkenazi, they have value in sort of interrogating very specific genomic and exposure environments to come up with solutions for pharma, for healthcare, for all kinds of other things. But for us as indigenous people of the Americas, we've been here for 40,000 years by ourselves. We've had several bottlenecks. We represent, 2 continents of people. Like the huge amount of value that we will provide to the world in terms of precision medicine will not come back to us. We are a commodity. We are the data. We
Yeah.
are the data treasure chest. Because the way I see Native Americans is we are the Rosetta Stone for African genomes. African genomes are the most diverse, the most complex. We are the least diverse, least complex. We will be the unlocking. We will be the key for everything, but we will get nothing for it.
Yeah, it's respect for persons individually, respect for persons collectively, respect for populations and cultures, those who are more vulnerable amongst us. It's just everything's just turbocharged to another level when you introduce AI and the sort of massive amounts of money that's going into it, and resources that are being directed in a way that is, true to our capitalistic system. So these are really challenging topics. I'm grateful to have the opportunity to bring this up and hear from everyone. And I wonder how we need to get ourselves together and start having some really concrete infrastructure that allows us to tackle some of these questions at the scale that's required. It's challenging, but it's also urgent and also critical.
Well, thank you so much for sharing your knowledge with our group today. I hope you'll come back and join us for future discussions. We're open to everyone, and thank you again and I think you're on vacation right now. I'm not sure.
I am. I'm going to go to the beach. So yeah.
So thank you again for taking time during your vacation. It was really great to see you and hear from you. And for everyone else, thanks for participating, and we'll see you next month in October. As always, we record these. We'll post them up on the Bridge to AI website and send out information about October's meeting. See you then. Have a good rest of your day. Thank you.
Thank you, everyone. Bye-bye.
Bye.